Jose, welcome back, everyone. Clearly, this is an important topic. If I see how many people are attending this session, and I think there's been a few trials lately that have, stimulated our interest as cardiologists in left main interventions. The Syntax trial, Noble, and Excel, as you are all aware of. Especially in low and intermediate risk patients, the 5-year outcomes are equivalent. But I think if we as cardiologists want to show, equivalent long-term results with percutaneous interventions, then we obviously have to, up our game. And I think part of it is that IVUS or intravascular imaging is essential to be able to get good results with percutaneous intervention so that we can have equivalent long-term outcomes to our surgical colleagues. So Peter is going to give a talk on IVUS and also with specifically pertaining to left main interventions. The left main is truly the biggest bifurcation in the coronary circulation. And I mean, it supplies about 80% of the myocardium, so it's really something that we have to get right. And then we have a pre-recorded case that Farrell did to also just highlight the important issues. So with much further ado, I'm going to hand over to Peter.
All right, thank you, John. Word of thanks to Boston for organizing the session. And in particular, thank you for allowing me to use your slides, so that I didn't have to go and spend several hours doing the same thing. So we're going to talk about, it's not an in-depth talk about IVUS, but it's more in terms of how we view IVUS and a sort of an approach how to use IVUS and what it might offer, and have a stepwise approach and how to use it to assess pre-stenting and post-stenting results. So the goal of PCI is to provide safe an effective and durable stenting result, or whatever you use, whether it's DCB or stenting, but you want to deliver a safe and effective and durable result. So we're going to talk about measurement errors, which might lead to higher complication rates or longer or less durable results. And certainly as complexity of coronary intervention increases, your eye is not the most reliable source when you plan stenting or any kind of interventional procedure. We're going to talk about intravascular imaging and how that reduces errors and reduce cognitive load. So it's less things you have to thumbsuck or guess and have the answer ready for a good result, and simplifying PCI. This is quite a nice sort of example of what does IVUS offer you. And it basically, the analogy is you turn the lights on. It's like navigating a treacherous road without the lights at night. And we only see a luminogram when we do an angiogram. And when we do IVUS, we see what the artery looks like, and we can see the obstacles. And I think when it comes to fibrotic or lipid-rich disease, probably doesn't come to its right, but certainly in the space of working with calcified coronaries, IVUS usually gives you a better insight of what's going on in the coronaries, as well as bifurcation, in particular with left main. I think the case that Farrell's going to show, IVUS was quite instrumental in the final PCI strategy, which differed from pre-IVUS. We can also see that even QCA is not a reliable source in truly estimating vessel size if you compare it to true measurements with IVUS. And especially the larger the lumen of the vessel, or the larger vessels, you have errors even with QCA, not even mentioning your eye, which we know in physiology, we can't trust our eye really. So as an example, there was a stent placed in the proximal right coronary artery. And angiographically, I think you would accept that as a decent result. That's where the stent was placed. And performing IVUS, you can see that the stent was grossly undersized with malapposition. So if you had performed IVUS in this case before you implanted the stent, you would have known the size of your stent. And if you find yourself in this situation, you hope you have a stent that can expand into the vessel size. So pre-stenting IVUS is essential. In my view, probably more important than post-stent IVUS, which is not unimportant. But you get to know what you deal with, and you get to plan the procedure appropriately. Just an example, we can see that even in severe calcium, where there's 270 to 300 degrees of calcium, only about 85% of that can be detected on fluoroscopic imaging only. So even with severe calcium, you might underestimate this just looking at angiography. And my philosophy is, if you see calcium, if you can get the IVUS probe down, do it. You're never going to regret it. Just an example that when you increase complexity of a case, there's so much more to consider and so much more that you have to take in and assess. And with increasing complexity, errors come in and you need more exact science to get a nice result. Oh, sorry. This is another sort of nice animation. Let's see if it plays. And basically, it's comparing diagnostic or fluoroscopic guidance with PCI versus seeing what happens in the artery before you navigate the intervention. And you can see the obstacles, and you can try and avoid it in advance with calcium modification as necessary, correct stent size, correct stent length. So I find myself using IVUS more and more, because once you start using IVUS, you can actually see what you're dealing with, and then you realize that you can't trust your eye. I mean, we did the femoral access session this morning, and also once we started using ultrasound-guided femoral puncture, you realize what you're dealing with if when you see it, where if you just puncture blind, you have a higher rate of vascular complication. And why is that not also applicable to coronaries? Knowing what you're dealing with and effectively modifying lesion before stent implantation and having the correct size. So the IVUS 1, 2, 3 is basically like using SatNav for your coronary stenting procedure, where you want to assess your route, plan it, and avoid obstacles. So the 1, 2, 3 principle of before stent implantation is you can use IVUS to exactly determine the length of the stent that you need to use, or the length of the lesion. You can assess plaque morphology and whether any calcium modification or cutting balloon or just pre-dilatation of the lesion is required, and you have your distal and proximal reference size. So as examples of this, this is when you hook the IVUS catheter up to its automatic pullback sled, you can get precise measurements of your lesion length from your distal landing zone to your optimal proximal landing zone. It's perhaps something that I could use a bit more, but I do find the sled is a bit cumbersome on my table, but it certainly is a value add if you want to use it. It takes the guesswork out of length. And you can see there, this will be the healthy distal vessel reference. And there's an example of less than 50% stenosis with some calcium between 3 o'clock and 5 o'clock. And there you can see a fibrotic lesion. And it's basically just to illustrate where's your landing zone going to be. You want to land your stent in an artery as close to that, proximal and distal. So we can assess plaque morphology, which will largely determine how you're going to predilate or how you're going to pre-treat this lesion before stent implantation. And so this is mixed lipophilic plaque, where you can see the lumen is there, and all this is lipophilic plaque. It's got very much the same sort of density as the outer layer of the vessel. Fibrotic plaque is a bit more dense, but you can see through fibrotic plaque. And then the enemy of the interventionist is calcium, where you can see a dense white line stretching from 12 o'clock to about 6 o'clock there. So this would be a 180-degree arc of calcium with sonar dropout behind it, which is classic for ultrasound, or for IVUS. So if you see a lesion where you can't see, you get an echo shadow behind it, that's calcium. And pretty straightforward. You find a healthy spot distal and proximal to your lesion, and you measure the vessel size and plan your stent. You try and identify a stent that can match your distal vessel reference, that can expand and post-expand to your proximal vessel reference. Okay. So this is all pre-stent. Whether you're going to, the degree of calcium that you see is going to determine whether you need to do specific or dedicated calcium modifications, such as rotation atherectomy, cutting balloons, or IVL. And once you've modified the lesion and you've implanted your stent, you again have a 1, 2, 3 sort of workflow to assess the result and make sure that you're not leaving the patient with a suboptimal result. And so firstly is to check for geographical miss and edge dissection. So geographical miss is where you implant the stent in an unhealthy segment of the vessel, which if you have diffuse disease, it's quite easy to miss that unless if you do IVUS and find a nice optimal landing zone. And edge dissection, which we'll show a bit later. You want to check for malapposition within the lesion. Make sure that the stent is well opposed to your vessel, that there's no space between the vessel wall and your stent. And you want to check for optimal stent expansion, so that distal, mid, and proximal, that you have aiming for a 90% stent expansion compared to your vessel reference size. As examples of these, this is a very optimally placed stent where you can see the healthy vessel starts, or the healthy vessel is with stents very well opposed with no edge dissection and in a healthy segment. This is geographical miss, where the stent was placed still in a diseased segment. I think this is, I think if you start doing IVUS post-stenting, you would be surprised at how often you see this. If you haven't done IVUS before, to identify a healthy landing zone. And we can see here at sort of 6, 7 o'clock, you can see stent edge dissection with a subintimal hematoma. Checking for malapposition, so you can see there that the stent is very well opposed to the vessel wall, certainly more than 90% of the vessel reference size. And you can see there that the stent is not well opposed and basically sort of free floating within the vessel. And the last and the third step on your post-stent evaluation is to check for optimal stent expansion. So you have your distal and proximal vessel reference. And when you do IVUS, you just make sure that you are at least 90% of your vessel reference size. This is sort of a repetitive slides, but you can clearly see in this slide that you have a large vessel with a suboptimal underexpanded stent. And coming back to the basics, why would you want to guess? Especially with complex cases, especially when there's calcified disease, why do you want to guess? Rather get the answers, exact science, and get a good result. I think that's the end. There's a few other slides that I just put at the back, but that's the end of my slides. In the interest of time, I'm going to hand over to Farrell for his case.
Thank you, Peter.
Yes, thank you very much. It's a great honor for us to be doing this and transmitting to you. And I'm really delighted to have Julian, who's come all the way from Bristol to stand by my side.
It was a great pleasure. Thank you.
Let's show you our case. He's a retired university professor of mining engineering who's an active 89-year-old and remarkably in fantastic condition despite his age. Chronologically, he's much younger than 89. He's a type 2 diabetic. He's got mild renal impairment with an EGFR of 48. He's got a good hemoglobin and he needs a hip replacement. He's had both knees done and now he needs a hip replacement, and he has stiff dyspnea. He has a background of pulmonary hypertension from working in the mines with some degree of silicosis, and he smoked until age 50. But as part of his workup, because he couldn't do a treadmill test, he had a coronary angiogram at another center because of his recently worsening dyspnea. So he has an unremarkable ECG apart from some unifocal ventricular ectopy. On echocardiography, his ejection fraction 60%, mild mitral regurgitation, moderate tricuspid regurgitation with pulmonary hypertension with systolic pressure of 65 millimeters of mercury. And then he had angiography at another center where they failed to get radial access due to tortuosity and used the femoral approach and struggled with requiring a long sheath due to tortuosity as well. This is what they found. He has a right coronary with an intermediate lesion in just after the first bend. Dominant large right coronary artery, and the left coronary artery, you can see in the spider view, he has a distal left main stenosis and a proximal circumflex lesion. The circumflex originates at 90 degrees, and the ostium of the LAD doesn't look too bad. This is a cranial projection showing how tight the distal left main is, and the origin is not bad. The ostium is quite open. You can see some calcification, which will show you better. There's an RAO caudal image. This is an LAO image showing the distal left main and the origin of the left main, the ostium. And they did an LV in their center. We don't normally do LVs in our diagnostic angiograms, but you can see good LV function. So to summarize, he's got a distal left main with a proximal circumflex lesion. These are the still images. And this intermediate right coronary lesion. So he's a symptomatic patient with a distal left main stenosis and a proximal circumflex lesion, a wide angle bifurcation, and a right coronary lesion of uncertain significance. So our strategy has been to physiologically assess the right coronary and to do IVUS guided planning of the left main intervention for sizing, lesion preparation, and to decide which vessel to stent first. And we plan to IVUS at the end of the procedure. So let us show you what we've done. I'll show you the angiograms and then hand over to Julian to look at the IVUS. So we're using radial approach. We managed to overcome the tortuosity. And you can see we've got a guidezilla guide extension because of the difficult engagement. So we engaged with a wire and then pushed the guidezilla over. 6 French JR4. And you can see this intermediate lesion of the right coronary. And then we did physiology of that lesion. So we've got a DFR of 0.90, right on the borderline. So we decided in view of this difficult access and the fact that we're going to be doing an unprotected left main, because it's borderline, we decided to stent this. So we put a 3.5 by 16 millimeter Megatron stent. Yeah, there you can see the Megatron stent in position. There's the final result. That was direct stenting, and that was a good result of the right. So we've done with the right, and then we'll show you the images of the left. So now you can see there's a lot of calcium in the ostium of the left main. You can see it just above the catheter. And then you can see the distal left main stenosis and the angulation of the circumflex, and some suspicion of pinching of the ostium of the LAD. We'll show you a cranial picture next. And that shows you just how tight this left main is. We've done this. The distal left main. There's this lesion in the circumflex, in the proximal circumflex, just after that small first OM. We really want to not be too aggressive in terms of how much stenting we put in here. What we want to do is get a good result and see if we can get away potentially with one stent. And we want to show the IVUS imaging and show you how that may help us in making that decision.
This is our distal circ. So this is then that severe lesion in the mid-circ or mid-proximal circ. this is a little landing zone just prior. And so we're going to land on B3 distally, but this is now dragging back, and this is pulling back from that proximal circ in towards the left main. And you can see here, it's a fairly non-diseased vessel, but a plaque of calcium is coming up here. Yeah. And then as we come back towards this left main, that increases. A few more shelves, but again, a reasonable size area. And then this is our LAD coming in. You can see this really severe lesion here. Yeah. A bit of calcium at the ostium, the LAD wires coming in at 9 o'clock. And then this is our distal left main. With again, you're losing quite a lot of dropout with, fairly impressive amounts of calcium. I'll just come back to the lesion here as well. Again, heavy amounts of calcific burden with almost a total loss of reverberation into the peripheries. Yeah, that's 20 millimeters down from the ostium of the CX. So this is, B3 is distal. This is sort of 20 millimeters down into the CX. This is then pulling back towards ostium of the circumflex. That's your distal left main there. And then that's back further.
I think what's interesting to see that frame, if you can go to that last frame and just show the ostial LAD, you can see the wire there in the ostial LAD coming in at 8 o'clock. And you can see it's a large vessel. The LAD ostium is pretty big and looks relatively undiseased.
Yeah.
So that's slightly encouraging. So we've then gone on, this is your LAD. So this is distal LAD, big artery. And then as we pull back, this is our circumflex ostium coming in. I'm just going to drag back slowly here, and you'll see that it's a circumflex wire just hugging the inferior border of the circumflex. And it's just a little bit more challenging here to say now, is the disease involving the ostium of the LAD a bit, or is it purely distal left main? What?
So I'm thinking that there is some disease in the ostium of the LAD. It's just at the ostium, and you can see the residual lumen is still good with an area of 6.72 square millimeters. So it's a good residual lumen. But there is disease, and I'm sure if we can get some distal wiring of our stent, if we stent the circ first, we will be able to hopefully scaffold that. If we can get distal strut wiring at the carina, hopefully scaffold that without a need for a second stent.
Exactly, so distal left main, and then this is the proximal left main, so the body of the left main. So our 3 points of interest, that's the ostium of the LAD. We've got sort of two areas, as Farrell says, it's debatable the significance of that. Distal left main, body of left.
Right. The bit I find it.
I think, Prof, it will be interesting to see, just based on angiographic features from our audience, who would consider just by going with a two-stent strategy without doing an IVUS, looking at that, who would consider just doing two-stent strategy, or would you still just want to go with one stent after you've done the IVUS?
So, based on the IVUS, who would go with this two-stent strategy? Single-stent strategy? And the rest of you don't want to touch this lesion, obviously. Okay, so should we carry on?
Interesting here is, first of all, the circ is a big vessel. So if you look at an angiogram, there's this misperception, I think, the circ is very small, and you're going to have some issue with left main mismatch. That doesn't look like the case.
So we've put a C-on wire down the circumflex, and then we've taken a member, and we're tripping out this member now, and we've put a rotor wire. I tried to wire with a rotor wire drive. We have the rotor wire drive here, but I think I think we were making good progress, but I didn't want to take too much time wiring, so we decided to do an exchange since we had a wire down, trap down. So we're going to take out now the trap, and we've got a rotor blade wire down. We're planning to rotor blade the circumflex.
Does everybody agree with rotoblader here? Would anyone have gone with a different strategy? Dave, go to the mic.
I just wondered if you've ever done inverted crossover stenting to the side branch in a left main case and done a pot and then just open to the LAD. I wonder if you've ever done that. It's an interesting thought here. But the thing is for me that the circumflex ostium, maybe IVL, I mean, you're going to need a very big burr there. I think it's a very big vessel and it's not that critically narrowed. So I think I might think about IVL with the circ ostium.
Yeah, I think that's a good point. Anyone else for RVL? Is that a hands up for LVL? Yeah. Okay, yeah. So I think RVL is an option. The question is whether you'd get that circumflex crossed with an RVL balloon. Perhaps you would, but RVL is certainly an alternative. But because of that circumflex being so tight, the decision was to go with
with a 1.5 millimeter burr. We just de-air this guide. You can see some air in the guide after the trap.
And what's interesting is the first time I've used the rotor drive wire. We don't have it yet in Europe, and it's an impressive bit of kit actually. It does have a very good torque.
1.5. The CAD is negotiating the CAD. It's
interesting. I think the IVUS was a little bit more convincing. It was a 101 with the majority of the disease in this distal left main round into that circumflex.
Yeah, right.
And the guiding catheter is
it's a sheapless. It's a sheapless, and I forget what the name is. So I never use them. It's a Asahi sheapless 4.
Yeah, look at how the rotablation is going properly through the left main. They're still serving the proximal circ. They were successful. And this, from the angiographic point of view, let's see if a change was done in the IVUS. But they were able to negotiate that important angulation.
About rotational atherectomy is it's a great gateway to secondary therapy if you need it. And it doesn't make anything more complex once you've rotobladed. It makes everything easier. And I think that's probably why you chose it up front, Julian, I'm guessing.
Yeah, and I think, I was just given a great demonstration of how efficient it can be. That nice bit of teamwork, double operated case, but that was a rotablation done in 3 minutes, and no messing around. And we've debulked. Well, the worst thing you can have with the left main stem is a rotor regret, where you're really wishing you had debulked, and you're going to get better stem apposition and expansion.
So I rotoblate from the second operator position because I'm left-handed. I used my left hand on the knob. So if that was confusing how we did it, I just want to make sure we've done the main OM. There we go. And then we'll change to a CWES now, please. So we're going to see how it responds with the balloon now. We're not going to image yet. If it dilates with the balloon, introduce it, please. Then we'll stent, and then we'll do imaging after stenting. If we struggle to dilate with the balloon, then we'll do further assessment of what else needs to be done. But you can see the bird did some work, and once the bird does work, it normally means you've done some fracturing. I mean, if the bird goes through and doesn't do anything, then you have to question whether it's calcium or your bird's undersized. But it certainly worked in the left main and in the circumflex lesion.
Yeah, you lost the decelerations, didn't you?
Now we're going to pre-dilate with the 3.5 balloon now. But if you put a Y in.
Yeah, so we're just swapping on. Okay, so we're swapping out. So your point is, why swap now, not go on the rotor wire? I think the feeling is that we're probably done here with rotablation, but we can always swap back very quickly. And we're taking an extra support just to give us a bit of a.
Yeah, and also the extra support, I'm hoping, will narrow the bifurcation angle for recrossing.
Yeah.
For crossing and make life easier.
So this is getting a wire down the LAD. There were some comments where I've cut the audio because it was a bit confusing what people were saying. So I'll talk over those spots where there's no commentary. So this is a 3.5 millimeter balloon in the proximal circumflex to dilate that lesion. And as you could see from the IVUS, the circumflex was actually a 3.5 millimeter vessel, which I think if you had to poll the audience, I'm sure most of you would think it wasn't that big to start with. Then dilating the left main. And then we're going to put a megatron from the ostium of the left main into the circumflex.
So we pre-dilated the lesion. So we've taken a 3.5 NC down. We have taken a megatron stent. It didn't quite reach where we wanted it to be. So we're now just taken a 3/16 synergy. And with that, we are going to just treat our mid-circ, and then we're going to bring our megatron in.
So the balloon was good, well expanded, no?
Oh, yeah, so it went up to 12 atmospheres really nicely distally, and we took it up a bit higher, up to 16, 18.
Yeah, let's go there.
So just going up.
The operator worked, he did the job properly. See, the stent is fully expanded.
So then the megatron wouldn't go, it was catching on the stent edge, so that made life quite difficult, so we had to take that out. So the megatron would not go despite maneuvering the guide to try and reduce the angle, could not get it past the more distal stent, so that had to come out, and then took a balloon to dilate again, but despite that the balloon would still not go.
Give me a Godzilla, a 6 French Godzilla, and a new 2.5 balloon, please.
So it's just that angulation from the left main into circumflex is always underestimated and will always catch us out. So we try to mitigate it as much as possible with a supportive wire, but you know, we got little techniques to get ourselves around. So we'll use the guide extension now. You're going to keep the LED wire down?
Yes.
So with this Asai guide, there's 7.5 French actually, slightly bigger. So if you take a 6 French guide extension, you can keep the wire in.
And use that as an anchor too.
Yeah. That'd be a 5.0 almost. Let me just go up gently then to see if it pushes you off. Okay. Then getting the guide extension around now on that balloon.
So that's inchworming the guide over the guide extension over the balloon, and now we're able to deliver the stent through the guide extension. So you inflate a balloon and then push the guide over the guide extension over the balloon while it's deflating. Now getting the stent into the ostium of the left main. This is a cranial LAO projection, just about 10 cranial, 10 LAO, which is the best for you to visualize the ostium of the left main. You can clearly see the ostium of the left main coming off the aorta, and that gives you an optimal visualization of the landing zone for the stent, and that's the stent 3.5 millimeter megatron going into the circumflex. Wires jailed in the LAD, and then a pot with a 4.5 millimeter balloon. And the idea is to get the pot in the perfect position at the carina, not to be too distal, and to be distal enough. You don't want to be too proximal. You've got to push that stent into the LAD to try and scaffold the proximal LAD. And you can see the LAD ostium is not perfect there, but there's good flow in the LAD. And now, in order to engage the catheter, you have to remove the gelled wire in the LAD. Otherwise, the catheter, if you try and engage the catheter with a gelled wire, you can get longitudinal deformation of the stent because the wire is outside the stent. So in order to engage, the LAD wire was removed. You have to make sure there's flow there first. And now trying to aim for the distal strut at the carina with a fielder FC wire, you can see a spider view with careful aiming for the distal strut. That was distal strut wiring. You can see it went through a strut right at the carina and then going down the LAD. and then a kiss. So that's down the LAD. And then that allows the delivery of a 3.5 into the circumflex and a 4 millimeter balloon into the LAD. And you can see if you do a good pot, even an NC4O will go straight across. If your pot is right, your balloons will cross. So then there's 4O in the LAD going up, and then a high pressure inflation in the circumflex with a 3.5 balloon, and then a final kiss. And you want to minimize your overlap when you do this kiss. You don't want to come back too far to make sure the stent remains circular and not to create an elliptical shaped stent. So you keep your kiss close to the carina, just a small overlap like that. And then that's the angiographic result. You see how big the circumflex stent is and how big the circumflex actually was. The left main looks good. You see a little bit of pinching of the left main. Now the question is, what is that? So the idea is to do repeat ultrasound. You can see the IVUS now coming from LAD. And you can see the stent in the circumflex there. And you can see that the LAD ostium has actually been scaffolded by the stent. And there's the stent in the left main, big. I'll show you more pictures shortly. And then IVUS down the circumflex, looking at the well, there's the left main. You see the two wires. So this is in the left main. And you can see there is coverage of the ostium of the left main. See, there's the ostium, so the stent goes right up to the ostium. And then this is IVUS down the circumflex. You see the circumflex stent fully expanded, circular in shape, which is ideal. A little bit elliptical where there's more calcification. Coming to the proximal circ, you can see it's a big lumen, at least 3 to 3.5, so the stent's well expanded.
Yeah, Farwell, are you doing IVUS? You have finished?
We're pretty much done, I think. We're now into the left main, you can see.
So we've done a couple of IVUS ones. So what we've done, we've deployed the 3.5 by 32 megatron, post-dilated that up with a 4.5 pot with a 4.5, recrossed with a field at FC and had a 3.5 NC in the circ. So the 4.0 NC went very easily through the side struts, so we're able to kiss with a 3.5 and a...
So this is the angiographic result. We can just let that loop. So you can see we've got a nice big proximal circumflex, nice big left main, and the osteal LAD, you can see some calcium in the osteal LAD is clearly impacting the penetration of contrast. But we've got some IVUS images of that to show you now, which I think are very interesting. So
this is LAD. So this is just a couple of millimeters down. This is a point of interest that I've bookmarked. So that is the ostium of our, let me just stop it there and come back to that. So that, I think, is pretty well at the ostium. You can just see the stent. I'm going to just gently nudge it forward. You can see the struts there. And then there's a few other little bits of interest. You can see the circumflex below. This bit here, there's maybe a slight bit of malapposition in that ostial roof of the LAD back into the left main. This is the body of the left main, which looks absolutely phenomenal. And we can just let it play back along there. So I don't know whether you want to see any of that again, but I think it answers the question, have we got a excellent angiographic as well as an intravascular imaging of this vessel, and do we need to do anything more with this LAD? We've got an area of 8.8 millimeters squared, and we'll give you an area here. So, you know, we'll go to Andy Lewiniak's data. Are we going to hit? I'll do a quick trace assist just for speed. We've got 14 millimeters. I can make that a little bit bigger, squared in this body of this left main. So an excellent result for this channel.
I also think that getting the distal strut was really important, because I think a lot of effort needs to be put into that, because to make sure you get the stent right into the ostium of the LAD, and I think that does make a difference to get that little bit of scaffolding. And I really think that given the patient's age, his need for surgery in the short term, and the fact that we've got a single well-expanded huge stent, we can stop depth even after 1 month potentially, and he can have his operation, but we'd probably go for 3 months. And he's a stable case, not an acute coronary case. So I think that this is the best solution for him. Now, it just remains for me to thank you for the opportunity, and to thank Julian for being here. It's been a great pleasure working with him. I enjoyed it immensely. And to thank my team for their work. And I hope the rest of the Congress and meeting goes well. Thank you very much.
Thank you. Thank you. Goodbye.
Just to say what we did, because you saw there was that slight malposition, we actually did a final kiss with 2 4mm balloons when we went offline. So it's a 4 in the circ and a 4 in the LAD. And that's the final angiographic pictures.
May I ask a question, Farrell? I mean, you did a pre-intervention IVUS, and you saw that the proximal circ was quite a large vessel. Your choice of burr, I mean, was 1.5. Couldn't you have upsized to, I mean, at least a 2?
So I think the thing is that the calcium was very, very superficial in both the left main and the circumflex. So the burr and the lesion was tight. So the burr certainly did a lot of work in the left main. There were a lot of decelerations in the left main and in the circumflex. And I think because of the angulation into the circumflex, it is best to start with a safe approach. And if your burr does a lot of work, then you're usually done. If your burr doesn't work, then it's either undersized or the calcium is deep and you're not reaching it. So I think because the burr did a lot of work, that gives you an indication you've done some fracturing, and most of the time you will dilate well. There'll be 1 or 2 cases every now and then, and it's happened to all of us, that the burr's done some work, but there's so much calcium that you still can't dilate. And then we do now have bailout with shockwave for those kind of scenarios if we have to.
Just your opinion on when you're looking at your distal reference and you have these patients with a large plaque bed and with a positive remodeling, and you need to size your stent. Should you be downsizing your stent up by 0.5 or 0.25 after looking at your distal reference?
So the distal reference, if you're talking about you got to talk about the lumen, yes, the distal reference lumen, rather than a different distal reference vessel, where you're going to land your stent. So you size it to the distal reference lumen. And then you can post-dilate more proximally if you've got a very remodeled, positively remodeled. You can make it bigger within the stent, but your stent should be sized to the distal reference lumen so you don't get edge complications.
Thank you, Farrell. That was a very nice case. I think it's a very nice show of using IVUS and sort of simplifying what could be a complex bifurcation lesion. My question to you is, if you had you saw on IVUS that there was disease at the LAD ostium and didn't require a stent, but you then went with a final kiss, which I think we all would do now. Any consideration of using a drug-coated balloon rather than just a normal balloon because there was disease there?
I think it's something that people often ask as a question, and there's no data. I think it's a reasonable approach. I don't think it's wrong. But also the restenosis rate in a non-stenotic side branch, even the left main, is extremely low from a kiss. If there's a stenosis in the side branch and you do a kiss, then the restenosis becomes higher. So in a non-stenotic segment, I think big vessel like that, if you don't have a dissection or complication from the kiss, it's not necessary to use a drug-eluting balloon, but I don't think it's wrong. I think it's an option.
Okay.
So yeah, Farrell, just a comment. I mean, if I'm doing a case like this in Ghana where we don't have a rotor, I would just go with a cutter And although it prolongs the procedure, there's no doubt the procedure will be a lot longer. If I'm doing this in the UK, it's great. You have a rotor, so it's nice and quick. But if I was doing this in Ghana, where we don't have a rotor, it will be balloon, cutter, and then the stent. So, but they can be done, especially in a case like this where you don't have very deep calcium.
I think the problem in this case is the circumflex lesion, not so much the left main. The left main you might have got away with a cutting balloon, but the circumflex had 360 degrees of calcium. It was a proper ring. If you see that IVUS, there was absolute dropout all the way around. You just saw that little ring of calcium with no other visualization of the vessel, which means it's 360 degrees. And that's where you really need either a rotor or a shockwave. I think you might have really struggled in the circumflex with just a cutting balloon.
Very nice.
Good. Yeah. There's two questions.
Just a quick one. Used a 1.5, it's a beautiful case, by the way. Nice demonstration of IVUS guided bifurcation left main. Used a 1.5 millimeter burr, which I think you can get in a 6 French sheath, but used a 7 French sheath. And I'm guessing that's for your plan B if you get a stuck burr or some kind of issue like that. Maybe you could take us through that, how a 7 French guiding sheath helps if you get into trouble with your rotor burr.
Yes, I think that's an important question. I actually almost always use a 7 French sheath for a left main intervention because you've also got 2 large balloons, 2 4 millimeter balloons, NCs. You can get them through 6 French, but it's a hard work. If you've got any wire wrap whatsoever, you're going to struggle to get those 2 balloons through. So it makes your life a lot easier, and I don't think the extra morbidity of upsizing to 7 French is significant enough to warrant the hassle of doing it through 6 French. I know some people do. The other thing is, you know, you can put a guide extension as you saw and still keep your wire in the side branch like we did in the circumflex with 7 French. And if you use a 6 French guide extension. And if you do lose your burr, you know, you can get a 7 French guide extension over the burr. It allows you to retract the burr into the guide extension because a 6 French guide extension will only take a 1.25 burr, not a 1.5 burr. So I think it's important to use 7 French for these kind of interventions, in my view.
Very nice case. I have 3 questions. The first question is, do you have any idea about the rate of acute occlusion of the other branch if you are dealing with the reticulation in the bifurcation like left main? If we go with the run from the left main to the 6, the rate of acute occlusion of the LAD, if there is any predictive factor during the first assessment of the osteal LAD to predict if there is any need to protect LAD with the microcuts or big bang technique.
So I think actually what rotoblader does is reduce your risk of side branch loss by reducing the plaque burden in the main vessels. So actually the incidence of side branch loss is very low when you rotoblate the main vessel. And it can happen that you create a dissection with a rotoblator and you do lose the side branch, but that would be most unusual. I think it's actually something that's advocated to reduce your risk of side. When you think you've got a high risk of losing the branch, maybe that's an indication to do rotoblator in the main vessel to reduce your risk. Any other comments from the panel on that?
Prof, sometimes after doing the IVUS,
Talking to the mic if you don't mind.
Yeah. Sometimes after doing the IVUS, then you realize that, especially in diabetic patients, you realize that the vessel is diffusely diseased. And where would you choose your landing zone? Would you go all the way, have a metal jacket, or would you go to an area where there is about 10 to 20% plaque burden and land it there? Because then it becomes a problem that you end up having the temptation of covering everything that looks like plaque in the vessel.
So sometimes you will, he's got more questions, I'll let him answer. Well, he can ask his other questions. Let me just finish this, answer this one. So I think there are cases where you've got a non-ideal scenario and you don't have a good landing zone, and then you have to really make a compromise. You put it at the best place you can. Make sure you don't oversize, low pressure initial inflation, then post-dilate. So 12 atmospheres, then go to high pressure within the stent. But you try and find the best, most healthy landing zone you can. Of course, you don't want to make the stents unduly long. If there's no significant stenosis, you have to make compromises. It's a balancing act. The whole vessel will be diseased sometimes. You can't just go and stent the whole vessel because you're looking for a landing zone. You've got to find a reasonable spot to put your stent where you've got an acceptable residual lumen.
The second question is if, in this case, I don't think that you rely on the pre-assessment with IVUS to choose the size of the burr. If you have pre-sizing IVUS, do you have any wire bias? Because even if you have the correct size of the burr, and you have because the calcification in the pre-IVUS, we see that the arc, it's not really 360 degree. If we have the wire in the other part of the vessel, we have like a wire bias, and the atherectomy it's not doing to do the right job.
So wire bias can be favorable or unfavorable. Wire bias can bias you away from the plaque, whereas you actually become taking more risk because you're closer to the non-diseased side of the vessel if you've got eccentric plaque. Or wire bias can be favorable, drawing you towards the plaque. We're giving you more ablation with a smaller burr. And we had favorable bias in this case. And that's why 1.5 burr did a lot more ablation because we were biased towards the plaque. So if you have unfavorable wire bias, you can adjust that by adjusting the angulation of your guiding catheter in order to angle the wire in a more favorably biased position.
I think also we can slow the speed if you have negative wire bias. Yeah. If you slow the speed, we have like a more orbital.
Yes.
The area covered by the burr will be huger. The other question, it's not with the case. In your regular practice, do you assist recross during recross, after recrossing? Do you assist with IVUS?
Assess where you crossed.
After recrossing with the guide wire to the LAD in this case, if there is any interest to reassist with IVUS.
You mean to cross the...
After recrossing with the wire.
Yes, you can assess where you've crossed with IVUS in the main vessel, see where if you've crossed by the carina. But I think in this case we were quite clear that it was distal wire crossing. We had a good angiographic visualization of where we crossed. But I think getting distal wire crossing except for DK crush, where you must cross proximally, is very important.
Thank you.
Quick question, Farrell, from somebody that's done thousands and thousands of rotors. Often a big question when we do these kind of cases is, are you not concerned about the angulation of the circumflex and going in with the burr there? We saw that the angulation was quite tight. I mean, it struggled to deliver a stent here, to take a guide extension through. Is it really a contraindication to go around a 90-degree bend? I haven't found it. But
it's not a contraindication, but you do need to have experience. So when you're learning rotoblader, that's not the case to learn on. You need to start on more straight segments and cut your teeth on those sort of lesions, because there's a lot of the burr lacks control around these bends, and you tend to have a lot of burr jumping forward, and if your wire's not well positioned, actually it wasn't perfectly positioned. I don't know if any of you noticed the wire was in a little side branch when we were rotoblating, which we didn't notice at the time, which was not ideal. If you don't have control of your burr and it goes into that side branch, you can have a perforation or a burr stall. So I think it's important to do this when you've done 50, 100 cases rather than in your early experience. You want to sum up, John?
Can I give one more comment?
Yes.
Farrell? With these bends, in my lab in the UK, we have both orbital and rotor. And for these sorts of bends, I will go with an orbital in preference because it's just so much, well, don't know about safer, but it's far more comfortable going around those bends with an orbital atherectomy than a rotor. And you can also go back and forth without worrying about it being stuck.
Yeah, so orbital atherectomy ablates both antegrade and retrograde. As you're withdrawing, you also ablate. So I think that is an advantage, and it's a very good technology, an alternative option.
Thanks, Farrell. I think that was a great case. Well done, and I commend you on that. So yeah, I think we are running over time, so I'm going to close the session just by saying that I think IVUS is an invaluable tool for planning the procedure, but also to make sure that you've executed the procedure well and that you get good long-term results. So
and can I also encourage you to come to tomorrow morning's live case, where we will be doing a rotablator left main case again live. If you want to consolidate what you've learned today, tomorrow morning's the place to be.
Thank you.
Thanks.